Hello.
Mohan, கேக்குதா?
Yes, yes, sir. Clear, sir. Very clear. You are very clear. Very clear. Uh, audible, sir.
Yes, very much audible, very well.
Okay, sir. Right, sir. Thank you.
So good afternoon to you all. So I welcome you all for this MMC ROCC program, the Resident Orthopedic Clinical Classroom. So I thank Professor Tolgapian for organizing this program very well. Like as we planned last time, it's going to be a clinical long case from here. I thank Professor Mohan Kumar from Stanley Medical College, who is our guest center, who is going to join from there, and he'll be a faculty moderating with this presentation, as well as the postgraduates will also have an interaction, and they will also be presenting one short case. So with that, I hand it over to Professor Tolgapian for taking it forward. So the presenter is ready. So I hope everyone it is audible. And for the students who are joining from other centers, please post your queries in the chat box. And if there is any suggestions, I just request you to just fill up that Google form. We'll definitely take that into account, whether you want any topic to be discussed, any specific cases to be discussed, because it's going to be a monthly affair. And any other change of timing or anything, you can just suggest so that we'll try to improvise it more. So with that, we'll go on to the clinical presentation. So Mohan, it is clear. The voice is clear.
Very much. Yes,
Okay,
sir.
right. Thank
Yes,
you.
sir.
Okay, then we'll go ahead. Right. Gokul, you'll introduce yourself and then start presenting.
Hello. Good afternoon, sirs. Myself, graduate from Institute of Orthopedics and Traumatology, Madras Medical College. I welcome everyone who have gathered here and who have joined online as well for the case presentation.
Go on.
So today we have a 28-year-old male patient coming from Salem who is a driver by occupation, coming with chief complaints of pain in his left hip for the past 7 months and limping for the past 3 months.
No, you continue.
History of presenting illness. Patient was apparently normal 7 months back, after which patient developed pain in his left hip, which was insidious in onset, progressive in nature, dull aching type of pain. No history of any night pains or diurnal variation. Pain was initially relieved by medication, but for the past 3 months, the pain is worsening and the patient is not getting relieved of pain by medication or rest. No history of any referred pain. No history of pain in the opposite hip. There is history of limping present for the past 3 months, which is worsening over the past 3 months. But patient is not using any walking aid till now. Patient whose walking distance was not restricted prior to the problem. Now the patient is able to walk only up to 100 meters. After which he has to take rest. There is no history of trauma, no history of fever. There is no history of any small joint pain or early morning stiffness. There is no history of any stiffness in the neck or the back, but patient complains of intermittent back pain. There is no history of any redness of eyes or burning micturition. There is no altered bowel habits. There is no history of any skin lesions. Patient doesn't complain of any limb length discrepancy, but patient is not able to sit cross-legged. Patient is not able to squat. Patient is not able to climb stairs. And for the past 5 months, he has not been able to go to his daily occupation, which is driving. Patient is not doing it for the past 5 months. There is no history of similar complaints in any other joint. Past histories. Though patient is not telling it as a presenting complaint, patient is complaining of short stature, which he noticed at around 14 years of age. Till that, he was of comparable height to his contemporaries and students. After 14 years, he noticed that his height was not progressing, and at present he is complaining of short statures. But till now, he hasn't gone to hospital to evaluate it, or no treatment has been done for that.
What is his age, you said?
28.
28.
There is no patient doesn't have any comorbidities. There is no history of any previous surgeries or prolonged hospitalization. No history of any chronic drug intake other than the over-the-counter drugs for the left hip pains. There is a similar complaint in his family, where his younger brother is of a short stature. He's a second-born child of a non-consanguineous marriage, normal vaginal delivery. His younger brother is of a short stature. His elder sister doesn't have any such complaints. No history of any joint complaints in the family. No history of any contact with tuberculosis. Patient is not an alcoholic or smoker. Normal bowel and bladder habits. From history, patient is having a progressive unilateral left hip pathology.
Apart from that, you said that at the age of 14, he noticed that his growth is not commensurate with the normal adult of his age.
Yes.
So what are the problems you think you have to elaborate? So what are the changes? Yeah.
Second, any secondary sexual characters.
So that is very important period. So that is a period of a man's growth spurt which takes place, adolescence takes place. So at that time there was some lag in his growth. So all the other developmental milestones which it happened correctly or not, because you said that also his younger brother has similar complaints.
Yes, sir.
So there should be some genetic predisposition for this problem. We don't know. So all the other things you have to ask. So you also thought that as the patient we would have examined completely. Patient is short statured for his age. So bearing that in mind, what are the other histories you should ask? So it is very good that you asked about the consanguinity. Younger sibling has got that problem. Apart from that, what are the other things?
Sir, any parents, previous generations,
Okay, that you have
reason-
told. Yeah, we'll assume that there is nobody else. Then secondary sexual characters, you have to elaborate. Anything else? Any history you could ask? His
sexual
orientation and anything else?
age is 28. Sir. So
Okay.
we can ask about sexual drive.
Yes. So did you ask him? So even if it is need not be very elaborate, you have to make a mention about it. So the patient can understand English?
No, sir.
Right.
It does. Didn't ask.
Huh?
I didn't ask.
Right. Okay. So what is his profession?
Drivers.
Driver. Okay. Just tell. Did you ask? Did you make an attempt? You did.
Tried, sir, but no, sir.
You tried, but you could not elicit. So this is one thing which you should keep in mind. Okay. Any other thing you'll ask?
Sir, body and facial hairs is
Yes.
history we can ask. Any if it's normal, normally he's growing a beard and mustache, or
Yes.
he's doing shaving regularly or something like that.
Okay.
He's
So
not doing.
He is not doing.
Yes, sir.
So there is a sparsity of the hair.
Yes, sir.
So there is some endocrine problem what you have to think. Okay. So in the pediatric age group, is there anything which is significant?
Gonadal development, have you asked? Or
Sir,
Okay. Right. So in the developmental before 14 years,
no, sir.
Was there
No
anything?
delay in milestones.
no delay in
Yes.
milestone. Okay. Go ahead. So if you suspect any pediatric developmental or congenital causes, then you have to start from the antenatal antenatal history, the order of the birth to the immediate postnatal and the milestones, even if if he is 28 years. Okay, right.
General examinations.
Yeah, anything from there, Stanley, if there is anything, you just ask. Any other further questions or elaboration?
Doctor, any similar episode in the childhood, similar problem in the hip on and
No, sir.
similar?
No, sir. No complaints till now, sir.
No, is it absolutely normal?
Yes, sir.
And all the problems are only for 3 months.
Yes, sir. 7 months.
7 months. Okay, fine.
Okay, go ahead.
General examinations. Patient is conscious oriented. Patient is of short stature and moderately built. Tattooing present in the bilateral pectoral region. There is no neurogenius markers. No generalized ligamentous laxity. Tattooing.
Tattooing. Okay.
No generalized ligamentous laxity.
So when you're telling about the stature, short stature,
Yes.
you have to quantify.
Yes. Next.
No, immediately as soon as you say.
Yes.
Don't ask us to wait. That's what we are giving a
Yes.
pass. So he's short statured and everything, all the parameters. Before you go to the other things.
Yes.
Yeah.
His arm span to height ratio is more than 1. His height is 8 centimeters less than his arm span.
So what does it indicate?
Sir, disproportionate short statues.
Okay.
Yes, sir. And upper segment is 18 centimeter less than the lower segments. Less than upper segment lower segment ratio is less than 1.
Okay.
So more of truncal dwarfism.
So if there is truncal dwarfism, what are the conditions you will think?
You have to think of storage disorders, dysplasias like spondyloepiphyseal dysplasias.
So they are all associated with disproportionate dwarfism. So we have to say as proportionate or disproportionate. So if the general height for the age is not right, the arm span and the height ratio, as well as the trunk versus the lower limb dimension.
No palpable abdominal organomegalies. Head to toe examination, standing position.
No, you just tell. If there is
That's,
anything, we'll ask him to.
Patient examined standing position, head in center, left shoulder at a higher level compared to the right. There is loss of hair in the eyebrows. There is sparse facial hair. Prognathism is present.
Okay, you can just make him stand so that everyone will be able to see. Right. Elena, you can make him sit also. Okay, right. Yes.
So left shoulder at a higher level compared to the right. There is a barrel-shaped chest with the pectus excavatum.
Pectus excavatum. How do you see that? Okay.
There is a protuberant abdomen. A patient is able to stand plantigrade, not able to make out the antisuperior iliac spines.
Okay.
There is exaggerated lumbar lordosis.
கொஞ்சம் திரும்பி நில்லுங்க. Okay.
Exaggerated lumbar lordosis is present, and there is a thoracic scoliosis with convexity towards the left.
Okay. ஃபுல்லா திரும்பி இருங்க. Right.
There is a low hairline.
Okay.
With a short neck.
What else is more prominent?
A deep bilaterally there is a deep skin furrow and just below the costal margins.
Okay. So what can be the cause? ஐயா மேல உட்கார்ந்துக்கோங்க. So what is the
there is a exaggerated lumbar lordosis with a deep skin furrow on bilaterally, maybe spondylolisthesis.
So what are the other features posteriorly if you see?
There is a flat buttock. There may be a if in case of a spondylolisthesis there may be palpable steps.
So that is on palpation, inspection. The costocrystal distance, the deep furrow is it is indicated like the costocrystal distance is decreased. So, okay. Anything else you want to? Yes. So hold it close. Hold it close. Hold it.
Yes.
Okay.
Yes, sir. Sir, on sitting, sir, the left shoulder is still at the higher level compared to the right shoulder, and there is a thoracic scoliosis with convexity to the left.
No, is it correcting or not?
No, sir.
It is not correcting.
Not correcting.
Okay, what does it indicate?
It's a structural scoliosis.
Maybe structures. Okay, right.
On sitting,
No, in the history, have you elicited any radiating pain, any
No, sir.
neurological? No,
intermittent back pain in the back alone, sir, not radiating.
not radiating.
Yes.
Any neurological? Nothing.
No, sir.
Okay.
On sitting, there is no exaggerated lumbar lordosis on sitting. Bilateral knee at same levels. On lying down positions, there is no exaggerated lumbar lordosis. On inspection, antisuperior spine not able to make out. The left lower limb is in a internally rotated attitude compared to the right lower limbs. With the hip in neutral, knee in extension. Mal. So left lower limb is internal rotated compared to the right sides with the hip in neutral, knee in extension, and ankle and foot at a position of ease. There is no visible limb length discrepancies. There is போயிரு. அதுல லேப்ல எஸ் சார் இங்க இருந்து கம் இங்க இருந்தே கம் இப்போ நார்மலா ஃப்ரீயா விடும் லூஸா விடும் ஃப்ரீயா விடும்.
Mohan, can you appreciate the left is somewhat interrotated,
Left.
but in video it's seen as though it's right is interrotated.
Yeah, the top camera, I think we could appreciate some internal rotation, sir.
Okay.
No,
But
it
the
is
right
the
side-
right and left, it is flipped. So it doesn't look, எங்களுக்கு அதாவது the actual pathology is on the left, but it looks as if it is on the right side. So the image is flipped. Just for your information. In the image, video image, now it is corrected.
லெஃப்ட்
Yes, now it is corrected. Okay. Previously it was shown on the opposite side, reversed. Okay, you go ahead.
there is no visible limb length discrepancies, no visible no obvious muscle wasting.
Hello, hi. Excuse me.
Yes, sir.
Doctor?
Yes, sir.
Who is speaking?
Stand.
Hello.
Sir, yes,
Yeah,
sir.
we are able to hear you, but who is that?
I'm Dr. Prabhakar. Sir.
Okay, Prabhakar, now I am seeing, right. Yeah, please go ahead.
Uh, can you point the camera at the student?
Yeah.
Doctor,
Sir, yes, sir.
you have completed your history.
Yes, sir.
Now you are in the examination.
Yes, sir.
Based on your history, what is your probable diagnosis which you are leading to?
Based on history, patient is having a unilateral progressive hip pathology, sir. With the history of short stature and intermittent back pain, sir. So thinking in terms of inflammatory pathology, inflammatory or
What inflammatory? Pardon?
So what are the points in favor of your inflammatory pathology?
sir,
So what are the leading clues? It can be inflammatory pathology on the short statured who has got some developmental problem. But from the history, whatever your information you have got, what will be your first diagnosis? What are the probabilities? That's
sir,
what.
maybe it may be a part of developmental problems, developmental problem or a part of spectrum of disorders.
So you are looking at a developmental pathology, is it not?
Yes, sir.
And developmental pathology associated with the left hip
Yes, sir.
in a short statured individual.
Yes, sir.
Is it not?
Yes, sir.
Yeah. Okay, fine. Proceed, please. Thank you.
Yes, go ahead.
Sir, examination of left hips. Inspection. There is the skin over the. There is no exaggerated lumbar lordosis. On inspection, anti-suprailiac spine could not be made out. There is no swelling or fullness over the Scarpa's triangle. There is no swelling or fullness over the Scarpa's triangle. Skin over the Scarpa's triangle is normal. No dilated veins, scars, or sinuses. No visible pulsations. On inspection, greater trochanter could not be made out. The skin over the lateral aspect is normal. There is no dilated veins, scars, or sinuses. On the posterior aspect also, skin is normal. No globular mass or swelling. No visible pulsations.
Go ahead, be continuous.
Palpation of left hip. There is no exaggerated lumbar lordosis. Left anti-superior iliac spine is at a higher level compared to the right side. There is warmth is present over the Scarpa's triangle. Tenderness present over the anterior joint lines.
Can you just demonstrate that the left anticipal spine is at a higher level? So how will you locate the anticipal spine?
Initially palpate the pubic symphysis. Palpate along the inguinal ligaments.
Okay. So both sides simultaneously you can do it. Okay.
Simultaneously.
Yeah, do it, do it.
Don't just say it's along the
Yeah.
ligament.
Yes,
It's a go superior and lateral
Yes, sir.
along the ligament.
Okay.
First bony prominence.
Okay. Now you just
Yes, sir.
locate the anticipal spine. We know that you have located. So you just show it. Show it to us, demonstrate. No, show simultaneously so that it
simultaneously, yes,
will be. Yeah. Okay, right. It is at a higher level, right?
Yes.
There is
Sir, there is warmth and tenderness over anterior joint lines. Bilateral femoral pulses are felt equally on both sides.
Where do you feel for the anterior joint line?
Sir, 2 centimeter below and lateral to the mid-inguinal points.
Mid-inguinal point.
Sir, midpoint between the anti-superior iliac spine and pubic symphysis.
okay.
Sir, greater trochanter. Greater trochanter is left greater trochanter is higher level compared to the right sides.
Complete the palpatory findings.
There is warmth and tenderness
Warmth and
and
tenderness.
bilateral femoral pulses are felt equally, sir.
Any other mass palpable or not?
No, sir.
Yes.
No, sir. The left greater trochanter is at a higher level compared to the right sides. There is the surface of the trochanter is smooth. There is no irregularities. There is no broadening. Petrochantric and bitrochantric tenderness is present. Sir.
Both petrochantric as well as bitrochantric is present. Okay. So what do you mean by that?
Sir,
When the trochantric per se, petrochantric including the face. No, no, no. Why do you want to lift? Just to palpate. No, we assume that you have done all these things. Just palpate the trochanter. You want to keep it flexed or?
Yes, bilaterally trochanter is located posteriorly.
Okay.
Bilaterally it is at a posterior location.
So always you want to palpate the trochanter in flexed position only.
No, sir.
No, it's all right. Vali irukka? Press panna. Oh, right.
Sir, posterior joint line tenderness is present. Sir. There is no tenderness over sacroiliac joints. There is no palpable mass or swelling on the posterior aspects. There is no spinal tenderness posterior aspects. Sir, a moment. Sir. So there is a fixed adduction deformity of.
Where do you look for the posterior joint line tenderness?
Sir,
what is the name of the?
Sir, obus greater trochanter, sir. Medial 2/3 and lateral 1/3. Movements. There is a fixed adduction deformity of 10 degrees present in left hip, sir. And further adduction only jog of movements is.
No, no, no. First you finish off all the fixed deformities. Yes, you say that. So apart from fixed adduction deformity, there is no other deformity.
Yes, sir. Yes, sir. Present.
Why do you want to say, sir?
Yes.
Yeah.
Fixed adduction deformity of 10 degrees. Fixed external rotation deformity of 10 degrees in hip flexion, sir. And
in neutral position, you just tell,
yes, sir.
like as the hip is extended.
Yes, sir.
If there is fixed external rotation and flexion, we'll do it later.
Yes, sir. At in hip in extension, the limb is fixed in neutral in rotatory planes.
Okay.
Yes, sir. And on flexion, it is fixed in 10 degree.
So don't confuse everything to the
Yes, sir.
examiner. As the patient is lying down straight,
Yes, sir.
as you start examining the range of movement,
Yes,
you
sir.
tell all the fixed deformities first.
Yes.
Is there any fixed flexion deformity?
No, sir.
Right. So there is no fixed deformity in the sagittal plane.
Yes.
There is if it is coming up to neutral, then it means that it is not fixed in internal or external rotation. So in rotational plane, there is no fixed deformity. In coronal plane, there is a fixed adduction deformity of 10
10
degrees.
degrees.
So you can just confine yourself by saying that there is fixed adduction deformity of 10 degrees.
Yes, sir.
The other plane, there is no fixed deformity.
Yes.
Right. Now you start telling the movement.
Yes, left hip. I'm
Can,
just
can you just demonstrate the fixed adduction deformity of 10 degree?
ಕಾಲು move. So,
So what are you trying to do?
sir, I'm trying to exhaust whatever free adduction is possible, sir.
So first movement you are trying to you are trying to adduct.
Yes, sir.
The first movement that will be taking place is the free adduction which is possible in the left hip.
Yes.
Right. You adduct. Feel that it is the pelvis is already moved. Now is the anticipally expand at the same level?
Yes, sir. Yes, sir.
Yes.
Yes.
Right. So is this a fixed adduction deformity?
Check. Loose out. Yes, sir.
No. What should you do? First you said that I'll start adducting.
Yes, sir.
The free adduction is the first movement that is taking place. Then what happened?
Sir, pelvis. Both the pelvis is squared.
Then the pelvis came down.
Yes, sir.
After exhausting the free adduction, the pelvis got squared.
Yes, sir.
Both anticipally expand came to the normal levels. Then what did you do again?
Sir, have to again try to abduct the limbs.
Try to bring it to the neutral position. So this is what is complete description. Don't assume that the examiners will know. So when there is an adduction deformity, when the pelvis is, the anticipally expand is at a higher level, you should start saying that I'll start adducting the limb. The first movement that takes place is the free adduction. Then the anticipally expand comes down. Once it comes at the same level, I try to bring it to the midline. Then as the pelvis starts moving, I keep the limb and I measure. That is the fixed adduction deformity. Right? Can you demonstrate again? So hope everyone understands this. Right. You are adducting. Now the pelvis moves. Then what happens? Hip is squared.
Instead of moving just one limb, you can take hold of both limbs.
So one. Right. Now both are at the same level.
Yes, sir.
Right. What do you want to do again?
I'm to try to bring the limb back to neutral, sir.
Yes.
நீங்க இது பண்ணாதீங்க.
Now it starts moving.
Yes.
You keep it. And then you measure. Right? So this is the fixed, finding out what is the fixed adduction deformity. If it is painful limb, you can hold both lower limbs together and move. So that way, the pelvis only will move if you hold both ankles together, and then you can square and then find out how much is the fixed adduction deformity. Okay, right. Then tell.
Sir, fixed adduction deformity of 10 degrees. Sir, further adduction only jog of movements are possible. Flexion. I'm describing the passive range of motion. Flexion 0 to 80 degrees. Associated with pain, and more than 80 degrees restricted by pain and spasms.
The free available range also painful.
Yes, sir.
It's associated with pain.
Yes, sir.
Right. Can you just show flexion of 80 degree?
கால் மடக்கிறேன்.
Correct. Okay, 80° of movement.
Loose out. Sir, in limb in extension, in rotatory plane, the limb is in neutral, sir. Only jog of movements are present on both the internal and external rotations. And on in flexion, the
Can you just show?
Yes. Very good.
So what do you want to see?
Sir, to
இந்த இடத்துல வந்துரு. இங்க வந்துருங்க. இங்க. What do you want to see?
sir, to
Lower leg.
evaluate the rotation in with hip in extensions, putting the
Okay.
patient in prone positions.
Okay, show the normal
and
side. That is normal. Oh no, this is normal, right?
And flexing the knee to 90 degrees.
Okay,
Using the leg as a marker to for the amount of rotations.
so that is,
Normal seats.
no, you just go to the extreme and then tell what is the range.
Yes.
Ah,
Internal rotation in right hips, in flexions.
flexion.
Yes, sir.
Flexion or
Sir, yes, sir,
extension?
in extensions.
Right, don't confuse.
Yes.
So hip in extension you are checking by making the patient in prone,
Yes.
flexing the knee joint. Now you are checking the internal rotation.
rotation.
Right, do it.
Internal rotation in right hip 0 to 20 degrees.
Okay, external
External
rotation.
rotations 30 degrees.
Okay, so you have to be very careful. Your left hand should be on the pelvis so that you find out whether the pelvis is moving or not. Okay, then the affected hip. Okay. So just note that left hand is being kept on the pelvis so that whether the pelvis is moving or not, he is finding out. Okay.
Only jog of movements present in both internal and external.
Okay, and moving on either side, only the pelvis is moving. He is rocking the patient. Okay.
Sir, in flexion, the left hip, there is a 10-degree external rotation deformities.
Yeah, it shows.
இல்ல நீ லூஸ் ஆகுது இது லூஸ் ஆகுது further jog of movement.
Okay, so there is a fixed external rotation deformity of 10 degrees. So when you are doing, you have to try to bring the limb to the plane of the patient as much as possible. Try to take the knee to the midline as much as possible. It is slightly deviated outside. So that is one fallacy, but it is not possible in all patients. On flexion, it is going in for like an axis deviation. It is going to the same side shoulder. So try to bring it to the patient's axis and then try to check. You can see that there is a external rotation deformity of around 10 degrees. And then it is in the same position.
Yes, sir.
There is no rotation.
Yes, sir.
In flexion also.
Yes.
Okay. Right. Do you call this as differential rotation? What do you mean by differential rotation or sectoral sign?
No, sir. This is not a sectoral signs. In sectoral sign, due to the deformation of the femoral head, when flexing the hip, a different part of the articulating surface comes into the hips. So the internal rotation reduces. But here, there is only jog of movements. Both.
The rotation arc has not changed.
Sir, good morning, sir. This is Dr. Ramprasad.
I asked. Yes.
Sir, Dr. Ramprasad.
Yeah, tell me, Ramprasad.
Yes. Sir, by differential rotation, the candidate please answer. By differential rotation, what do you understand?
Sir, normally with hip in extensions, when you are the difference between the rotation in hip in extension and hip in flexion, in flexion, there will be 5 to 10 degree increase in the range of rotations.
No, it's not about generalized rotation. You should mention specifically which rotation, internal rotation or external rotation.
So internal rotation, internal rotation reduces on flexions.
That's what exactly opposite you are saying now. See, normally what happens is in flexion of the hip and flexion of the knee, when you are checking for internal rotation, the internal rotation will be slightly, that means 10 degree higher than that amount that we have seen in hip with extension. This is called differential rotation. So in extension of hip, you find, suppose there is a 20 degree of internal rotation, and in flexion of hip, you find there will be more. That means 25 to 30 degree of internal rotation will be there. This is called as differential rotation. But this differential rotation is not there when, as you said, there is a deformed head with irregularity in the superolateral and anterolateral aspect of the head. What happens is a different portion of the, that is the deformed portion of the head, comes in articulation with the joint surface in flexion. Therefore, the higher amount of internal rotation that we expect is not happening there. This is called pathological. That's what we call as sectoral sign. Sir, Singarul sir, do you want to?
Yeah. So normally we expect on flexion, the rotation should be little more. So if the rotation is decreased and that too decreased by more than 20 degree, then there is something significantly malformed femoral head which has engaged the acetabulum, which has resulted in the loss of rotation on flexion. So this is called as the sectoral sign or the differential rotation which it has resulted in. Okay. So that is what essentially what Professor Ram Prasad has told. So that should be there. Here, both in flexion and extension, the rotation is same.
Yes, sir.
So here, this is not called as the sectoral sign. Okay.
Sir, measurements. Sir, there is
One
no
more
upper.
Doctor,
Yes. Yes, Mohan.
you said there is no FFD, is it? Then what is the amount of extension available this hip?
Extension on affected side 0 to 5 degrees. 5 degree less compared to the normal sides.
Oh, no, what is 5 degree less or only 5 degree? So you meant to say only jog of extension possible.
What is the amount of extension in the left hip?
So 5 degrees.
5 degrees. What is the extension in right?
Slight.
Another 5 degree only, 10 degree only.
Yes.
Yeah, you just tell. That's what he's
Yes,
asking. Professor is asking only that.
Yes.
So there is 5 degree of extension available, which is around 5 degree lesser than. Only a jog of extension is possible. Right. Okay, go ahead.
Measurements. There is no apparent limb length discrepancies. True length, left side is 1 centimeter more when compared to right sides.
Left lower limb is more.
Yes, sir.
Apparent, there is no limb length discrepancy.
So in the segmentally, tibial segment is 1 centimeter longer on the left sides.
Tibial segment is 1 centimeter longer.
Yes.
What happened to the femoral segment and supratrochanteric?
Femoral segment same, bilaterally same. Tibial
So the
segment
length is more in tibial segment.
tibial.
Okay. Normally in an adduction deformity, what do you expect the apparent length?
Sir, there will be reduction in the apparent length.
Okay. So here it appears same.
Yes, sir. Apparent length is same.
Apparent length is same. Why in adduction deformity the apparent length appears shorter?
Sir, the patient tries to compensate by lifting up the pelvis. So
What he tries to compensate, what he tries to do?
sir, to bring both the limbs parallel so that he can walk, he tries to lift up the pelvis.
So the left hemipelvis is lifted up to make the limbs parallel in an adduction deformity. So that makes the that affected lower limb shorter. Okay. But here you feel that the tibial segment is longer and the femoral segment is intact.
Yes, sir.
Okay. Very unusual. Okay.
Sir, bilaterally there is no wasting, sir, the thigh and the calf compartments.
Okay.
Sir,
The right lower limb is normal.
normal.
Okay.
Sir,
Complete.
Brine's triangle, there is no supratrochanteric shortenings.
That's what you said,
Yes, sir.
right? Left segmental measurement is normal. Okay.
Special tests. Telescope is negative, sir. Trendelenburg test is positive.
Can you just demonstrate?
Kill.
He has to face straight or he has to turn? Nera, pinnadi. Ah. right? So the left lower limb is the affected limb, right?
First right side நின்னுட்டு அந்த கால் நார்மல் சீட்.
Okay, what do you see? From where you see? Okay. So now on bearing weight on the left side, what happens?
Sir, the right hemipelvis is
Tell boldly, don't say half and finished sentence.
right hemipelvis is dropping.
Right hemipelvis is sagging down. Okay. Can you just ask him to do it again?
இடது கால் first வலது கால் இல்லைங்க. First right side.
Now he is standing on the normal side. The left hemipelvis is getting lifted up. We all can appreciate. Okay. The same left side. Okay. So right side is definitely long. Is it significant? So you want to call this as positive Trendelenburg sign?
Yes, sir.
Yes. Anybody from Stanley? Anybody wants to, any postgraduate comment on this? So he says it is positive Trendelenburg sign. What is your comment? Tell.
He has a fixed deformity, so he has a fixed adduction deformity, sir.
Yes.
So, significant 30 seconds he should be able.
No, he's able to stand 30 seconds. He's able to stand 30 seconds, but is there any significance?
Sir,
If there is a fixed deformity of adduction deformity of 10 degree.
Yes, sir, there should be more than 5 centimeter drop in the level
Sorry,
of.
you are not clear. Can you repeat?
More than 5 centimeter drop in the level of PSI is for it to be called significant, sir. So can't be called significant.
Drop. No. So you are bringing new things. So if there is a presence of fixed adduction deformity, you expect the pelvis to be at a lower level. So it doesn't. So you need free adduction and abduction to carry significance for the Trendelenburg test. So here there is already a fixed adduction deformity. So when he stands on the affected side with the fixed adduction deformity, the pelvis is bound to come down. It cannot go up because there is no, for the hemipelvis to lift up, you need abduction. When it is not possible, then you cannot attribute any significance. Is it due to power arm? Is it due to lever arm? Or is it due to fulcrum? Okay. Okay. Right. Thank you. So when the examiner asks, in spite of that, if someone says, then I made him stand and the pelvis is coming down. But I cannot give any significance to that. Okay. Right. Then.
Yes.
Okay.
Hello.
Then, no. Before that, what else you have to finish?
Sir, modified Schober's test is positive.
Okay. What is that?
Sir,
how do you do?
Sir, we have to mark the level of the posterior superior iliac spines and 10 centimeter above and 5 centimeters below. We have to mark 2 points and ask the patient to flex as much as possible. And we have to see the increase.
You have marked all those things? Right, you do that now. No, you just ask him. So what you just mark it. In step. Help, Yashwant, help.
Triple of venous.
Okay.
Level of posterior superior iliac spines.
Okay. So all these things you have to do. Don't keep on saying just theoretically. கொஞ்சம் close up காமிங்க. Okay. Then 5 centimeters below. Okay. What do you want to do?
Ask the patient to bend forward as
right.
much as
possible. Okay, bend.
So you have to measure the.
Already have measured.
Yes, sir.
Right. 15 centimeters. Then. முடிஞ்ச அளவுக்கு குனிங்க. Right. What do you want to measure now? Fast man, how long he can keep on bending? So how much is it?
19.
19. So how much it has increased?
4 centimeters.
So how much you expect?
More than 5 centimeter increase.
Okay. There is slight decrease in the amount. Okay. Then
Sir, Nelaton's line.
you are going from there to here, here to there. So many things here. Right. What are the lines you drew?
Sir, Nelaton's line,
Hmm.
Shoemaker's lines,
Hmm.
and Chinese parallelograms.
Okay.
Sir, Nelaton's line bilaterally, the tip of the trochanter is the.
So there is no change.
No, sir.
Okay. Then
Shoemaker's line bilaterally meeting in the midlines.
okay.
And Chinese parallelogram are
Parallel.
parallel.
Okay.
Pelvic compression test is negative.
Okay.
So what about the Bryan's triangle measurements?
He said everything was symmetrical. So Bryan's triangle was symmetrical. The thigh segmental measurement was symmetrical. Only the leg segment has increased.
But you said the
Yeah.
greater trochanter was shifted posteriorly in your supine examination. That means will that
Bilaterally.
in the Bryan's triangle, 3 limbs of triangle is there, isn't it?
So bilaterally it is same. Sir. Bilaterally it is shifted posteriorly.
And you said trochanter is shifted posteriorly on the left hip.
The hypotenuse, did you measure? Did you measure the hypotenuse? You should have measured that. So if the trochanter is shifted, the base also is important. Hypotenuse is also important. How much it is gone behind? Because you said that the limb is internally rotated, but the trochanter is elevated.
Trochanter is posteriorly shifted. Do you expect any excessive anteversion in this patient?
Sir, yes, sir. There is no intowing or outowing in the gates.
Have you performed the Craig's test in this patient to identify the amount of anteversion?
Sir, left hip is it is fixed, is it? So I'm not able to do Craig's test.
He's not able to do the Craig's because of no rotation possible. Okay. Agreed.
The left hip fixed.
Sir?
Yeah, left hip, I heard it. Is it in flexion also?
Prabhakar, your voice is breaking.
Is the hip fixed in flexion also, doctor?
Yeah, there was no rotation. Flexion as well as extension, it was only a jog. No movement was there.
Okay.
Okay.
In the extension
What?
of hip is fixed in neutral position.
Yeah.
And in of hip, the hip is was fixed in about 10 degree of external rotation.
Yes.
I'm correct.
Yeah.
Am I right?
Continue. Correct.
Yes. Intermittently, it is breaking, sir. The voice is breaking.
Okay. Your voice is completely coming.
Okay,
Yeah.
sir.
Yeah.
Sir, ipsilateral knee is normal.
Did you tell about the gait?
Gait.
You finish off that because don't take it to the end.
Yes.
So as soon as you finish that lines, you have to tell about the gait before you go in for spine and other things. Right? Gait.
Sir, gait, bipedal, biphasic, and unaided gaits. The
Trendelenburg component. Yeah, can you just make him walk? நடக்கிறது அப்படியே எடுங்க வீடியோ இங்கிருந்து அது வரைக்கும் போயிட்டு வாங்க கேர்ஃபுல்லா ஓகே Okay. So we cannot give an antalgic component and there is slight going of the drooping of the gluteal region. Right. Okay.
Sir,
anything else you want to say?
Sir, examination of spine, the lateral bending is also restricted.
Mm-hmm. So how do you quantify and
Sir, we have to.
You call this gait as a stiff hip gait? Because Trendelenburg's gait you cannot call because there is a 20 degree of fixed reduction deformity. The Trendelenburg component doesn't enter here. And sir said it doesn't look like a classical antalgic gait. And the patient is taking, he's taking the foot forwards with a minimal flexion of the hip, and he is not abducting his hip to clear the ground.
கொஞ்சம் ஒரு தடவை நடங்க நடங்க. So it is very difficult to say a stiff hip because the pelvis is not rolling during the stance phase of the affected limb. So that is very, very classical in a stiff hip gait. The pelvis must roll on the hip when he is doing the
You mean
swing? Yes, the swing phase of the affected hip and the stance phase of the normal hip. So that the classical rolling is not there because he has got some flexion of the hip which is possible. Trendelenburg, why we can to a certain extent, because it is not classical, it is not unstable, so it is not classical Trendelenburg. But since the shoulder and the gluteal region on the stance face of the affected side droops slightly down, so that is the only point. Otherwise, it is not very classical of a gait pattern. That's what I feel.
Yes, sir.
Okay.
Sir, ipsilateral knee and contralateral hip are normal. There is no distal neurovascular deficits, no palpable lymph nodes.
In between, I'd like to intervene. You said there is a lengthening of the tibial segment.
Yes, sir.
And the thigh segment appears to be normal.
Yes, sir.
So can you elicit in any test which segment is lengthened or shortened? Is there any method, clinical method?
Sir, I did the Alice test to check.
Yes, did you do that?
Yes, sir. Malapadum.
அந்த சைடுல போயிருங்க. சைடுல. சைடுல சைடு போஸ். சைடுல.
இங்க இல்ல இங்க
சைடுல இருந்துப்பா.
இங்க
சைடுல இருந்து.
இது
கரெக்ட்டா கீழ
இங்க இருந்து போ.
கரெக்ட். ரெட் லைட் வந்துருச்சு. வருது. கரெக்ட். இன்னும் கொஞ்சம் மேல தூக்கி. கரெக்ட். So this is the maximum you can show. 1 centimeter, a subtle difference. Okay. கொஞ்சம் மேல தூக்குப்பா. கொஞ்சம் மேல. Right.
Can you please keep the posterior borders of the heel together at same level?
So it is kept like that.
We are able to elicit the heightened patella on the left side. Slightly.
Sir, this is a
patella.
Yes, sir.
Yeah, there is a difference. கை வை. So you can see இத வந்து கரெக்ட்டா அந்த லெவலுக்கு கொண்டு வாங்க. இல்ல அப்படி கரெக்ட். அந்த லெவல்ல. கரெக்ட். That is the way you should be showing. இப்ப கையில பெட்டலால கை வை. ஒரு பென்சில். இன்னும் கொஞ்சம் நீங்க கீழே வரணுங்க கேமரா. அது கோணலா இருக்க கூடாது. இந்த சைடுல. Parallax error அதனால. Okay. Yeah.
And the thing is, one thing is you observed the patella is higher than, on the affected side, it is higher than the.
Correct.
And the apex of the patella should be just proximal of the pathological side when compared to the normal side. That
Correct.
means it is lengthened.
Yeah, both are there. As you say, both are there. And the ரெண்டு பெட்டலாம் ஒரே பென்ல வச்சு கனெக்ட் பண்ண. அந்த பென்னை வச்சே கனெக்ட் பண்ண. இல்லப்பா லோயர் போல் அந்த பெட்டலாம். Yeah. So it is just proximal and it is also gone up.
Yes, sir. We are able to observe from here.
But it is very difficult to demonstrate over video. We are trying all angles, but we are finding it difficult.
Yes, sir. But we are able to appreciate. Sir.
Yeah, yeah. And I from.
It's all right. We have accepted.
Okay. Accepted. Examiners have accepted. Okay, right. Okay, then.
Sir, chest expansion is 1 centimeter.
1.
Yes, sir.
Okay.
There is no distal neurovascular deficit or palpable lymph nodes.
So it is significant?
Yes, sir.
What is normal?
It's more than 3 centimeters.
Okay. So it is 1 centimeter. So the Schober's test is 4 centimeters and chest expansion is 1 centimeter. Okay, then.
Diagnosis.
Anything else you want to add? Okay. Right, anything else? So he wants to go for the anatomical diagnosis.
So before that, doctor, the other hip movements of normal? Are there any restriction of any plane of movement in the other hip also?
No, sir. Right hip is normal.
So the right hip is, the range of movements are normal? I'm asking.
Yes, sir. Yes, sir. Right hip is normal. Sir.
Right.
Okay.
Found that there was some restriction of rotational movements in the right hip also. What is the normal range of rotation, internal rotation, external rotation, in a normal person?
Sir, in extension, the internal rotation is 30 degrees.
Okay.
In flexion, around 35 degrees.
Okay. External.
External rotation in extension is 35 degrees. And in flexion is around 40 degrees.
Okay. Can you demonstrate in this patient?
Right hip.
Right hip.
இந்த பக்கம் வந்துரு கீழே. Okay.
External rotation.
Okay.
Almost slight decrease, we will say. For his age, we expect little more, but it's all right.
But without seeing the X-ray, we have to take these things as significant findings.
Yeah, correct. What you are saying is right.
Fundamental problem. He may have a pathology on the bilateral side and including the spine also. So we have to consider these things.
So don't, because if it is a generalized manifestation of a generalized problem, spine is involved, chest is involved. So it is very unlikely that the left hip alone is involved. And here there is, as Professor Ram Prasad mentions, it is definitely, it is reduced when compared to a normal person of his age. So when this is reduced, you have to take it as significant and you should, because you don't know what the X-ray is. So at least you should assume that you don't know. Then you have to at least say that the right hip, but for the rotation, which is restricted when compared to a normal, say 10 degree of rotation restriction, both internal and external, there is no tenderness, there is no pain, the range of movement, other movements are full. It is always better.
Other thing is, if there is a bilateral involvement, hip involvement in this patient, then obviously there will be no shortening as per your measurement. So there will be no shortening. The Bryan's triangle will be equal on both the sides. So that is another thing. So if you are thinking of bilateral hip with spine pathology, it is better to include this finding also so that your differential diagnosis will be better accepted.
A safer. Yes. This is a safer bet. Definitely agree with him.
Valid point.
Very, very valid point. Okay.
Diagnosis.
Yes.
Anatomical diagnosis. Arthritis of left hips. Chronic arthritis of left hips.
Okay, proceed. Why do you want to?
Pathological diagnosis. Secondary to part of a developmental pathology, sir. Like generalized.
So you want to give a differential diagnosis. Right. First, you'll say that there is nothing which is very, very pointing towards one diagnosis. Right. So what are the diagnoses you keep in mind?
To keep in mind, it may be secondary to a developmental pathology.
What problem?
Like spine is also involved. So dysplasia involving the spine and the spondyloepiphyseal dysplasias.
You
Okay.
said probably a developmental problem.
So
And
yeah, that's what I want to ask.
developmental problem, why not be a congenital problem?
Spondyloepiphyseal dysplasia is the first diagnosis you want to keep. Why do you want to put it as a developmental problem? Is it developmental or a congenital problem? Right. So don't make it as a developmental problem. First diagnosis may be a spondyloepiphyseal dysplasia is a acceptable diagnosis. Right. Anything else?
Inflammatory spondyloarthropathy, sir. I want to.
Mm-hmm. Okay.
And want to also keep in mind osteonecrosis of femoral.
Where from the osteonecrosis is coming? Absolutely. So as postgraduates, present day postgraduates, they cannot leave. In our days, we cannot leave tuberculosis. The present days, they cannot leave osteonecrosis, any patient. Alcoholic, non-alcoholic, 25 or 45, unilateral, bilateral, everything is falling under osteonecrosis. Osteonecrosis due to idiopathic.
Maybe due to a storage disorder.
Storage disorder. Oh, why do you want to think of storage disorder? That's a very good logic.
Facies absence of secondary sexual characters.
Okay.
Protuberant abdomen.
Okay.
Short trunk dwarfism. Disproportionate short trunk dwarfism.
Okay. Perfect. Right. Anything?
Doctor, in addition to this boy, he has one other sibling who's also short statured, is it not?
Yes, sir.
So add that to this and then now make a diagnosis.
Familial disorder.
Familial or genetic? Can it be genetic?
Genetic.
Can it be autosomal dominant?
X-linked.
No, because the sister is not involved, that doesn't mean it is to be X-linked. It can be an autosomal dominant with variable penetrance. So what is the possibility now? What about the trunk measurement?
Upper segment is 18 centimeters less than the lower segments.
So the upper segment is less than the lower segment.
Yes, sir.
Short. It is short.
Yes, sir.
Which means your axial skeleton is not growing normally.
Yes.
Okay. All right.
Professor Papakar, you want to think of anything specifically so that we'll all, what do you want the candidate to say?
No, sir, it's an interesting case.
Yes.
Now,
what were you keeping in mind?
Achondroplasia.
Achondroplasia. Okay. Right.
Going out of the window.
Okay.
I have to think of something else.
Okay, right. Okay, so
Epiphyseal dysplasia, I don't think it is possible because only hip joints are involved.
yeah.
Dysplasia, if it is going to be there, all other joints will be involved.
Yeah, definitely.
That also
Definitely.
That also
Yeah. A storage disorder is a very good possibility. Where the features are there, spine is involved, and avian following a storage disorder. Okay, right. We'll see. Anything? Any other comment? Right. Okay. So, shall we go in? What do you want to do?
So I want to confirm my diagnosis by taking X-rays.
Right. X-ray project.
Good. Kiloput.
Right. Read the X-ray. ஏன்பா நல்லா தானேப்பா இருக்கு? ஸ்கிரீன் ஷேர் ஆகலையா? ஏய், ஹோஸ்ட் டிசேபிள்டு பார்ட்டிசிபென்ட். இது நீ அந்த போடு ஸ்கிரீன் ஷேர, அது இவங்க வீடியோ எடுத்துருங்க. அது வீடியோ எடுங்க. அதை நீ போடு. நீ ஸ்கிரீன் ஷேர் பண்ணிட்டா அதை
Sir, plain X-ray of pelvis with both hips of a skeletally mature individual with good alignment of the good alignment.
Mohan, you are able to hear us?
No, sir. No, sir. Just
You are
now,
not able to.
just now what you are talking, we are able to hear. The candidate talking, we are not able to hear.
Wait. Now you are able to see?
Yes, sir.
Okay, right.
Sir, plain X-ray of pelvis with both hips of a skeletally mature individual with good alignment and with no focal or generalized osteopenia.
We have
Left
lost
hip.
audio connection, sir. We have lost the audio connection.
Yeah,
Hello, sir.
Yeah, I'm able to hear the hello, but after that,
we are
I'm
able to hear you.
Yes, sir. The left hip showing
Now you are able to hear?
left hip showing concentric reduction of joint space.
So what do you mean by concentric reduction?
Equal.
So where is the medial joint space? How do you look for medial joint space? So just trace medially and இல்ல பாயிண்டர் அங்க அந்த பாயிண்டர் தான். அந்த பாயிண்டர்ப்பா. அதுலயே வருமா? இல்ல இதுல பண்ணா அவங்களுக்கு தெரியாதுப்பா. அதுல உட்கார்ந்து பண்ணாதான் தெரியும். So you're able to see the pointer also.
Yes, sir.
So that is lateral. Where is medial? Where is the medial extent of the acetabulum?
Sorry.
That is the medial extent. So it is completely away from that teardrop and that is the joint. So medial side it is subluxing and it is going up. The head is going up. So when the head is moving up, you think that so when the head is moving up, you think it is a concentric narrowing. So never say this as a concentric narrowing. So this is the inferior extent, the medial, the teardrop, and this is the femoral head. So normally we expect, this is the teardrop. Normally we expect the head to be at the level of the teardrop. So if it is moving up, it is superior and lateral migration of the femoral head. It means that there is no concentric narrowing. Okay, right, proceed.
Again, we have lost audio connection, sir. Again, we have lost audio connection.
Yeah.
Okay. But if you say it's a concentric narrowing, the contour of the head should be spherical. But here it's not spherical. The head is deformed.
Okay, right. Next.
So there is
So just say there is a
joint space
narrowing. And what happened to the edges?
There is a loss of sphericity of the femoral head with subchondral sclerosis and cyst formation, and there is osteophyte formation, and both the osteophyte formation is present, and sclerosis is present, also present on the acetabular, and the femur is externally rotated. It's breaking the Shenton's lines.
Okay. So you talk about the
What happened to the neck?
Neck is short. Some
Shortening as well as the
some back.
breaking.
Because it's differential diagnosis, you have added something now. Wireless joint.
So you also should have a spine X-ray because you had some other issues
Yes, sir.
in the spine.
Yes,
Do you have a spine X-ray?
Spine X-ray.
Yes. Put the spine X-ray. That's
Yeah,
interesting.
Now,
Now tell, what does the spine X-ray show?
Sir, the APN lateral use of showing the lumbosacral spine with excessive exaggerated lumbar lordosis.
Okay.
The end plate sclerosis
Okay.
present in the lumbar regions with alteration in the shape of the vertebral bodies with anterior beaking.
Anterior beaking. Right. In what vertebrae, which vertebrae the anterior beaking is there?
Sir, L3, L4, L3,
L2 also there is something. So from L2, you just show for the benefit of the others. Right. So that is, which is the anterior aspect. And yes. So to that extent only the vertebral body extends.
Yes.
From there, there is a beaking of the vertebral body almost from L3, L2 to L5. That is very classical. Right. So is it, what are the types of beaking?
Sir, central beaking and the inferior beakings.
Okay. So what category does it fall in?
Sir, central beakings.
Okay. So central beaking signifies?
Sir, storage is or Marcus from central beakings.
Okay. Yeah. You
in
want.
disk space. I want to comment about anything on disc. What is in the disc?
Sclerosis.
Not sclerosis.
There is also, apart from sclerosis, what else you see? The end plates are sclerosed.
Yes, sir.
But apart from that, it is very classical in L12, L23.
Shiny corners.
Calcification of the disc. Okay.
Calcification.
Yes.
The disc is calcified.
Yes.
Is it not?
Yes.
So there are a lot of findings here. So there is calcified disc because you see the end plate clearly. Below that and above the inferior end plate, you see there is some calcification. That is a calcified disc. Right. What are the causes for calcified disc?
Sir, ankylosing spondylitis.
Ankylosing spondylitis.
No.
Anybody? Calcified discs. From Stanley? Anybody? Any postgraduate from Stanley?
Onchronosis.
Very good. What is achronosis?
Homogenesis.
Alkapnuria.
Yes.
That is otherwise called as the achronosis. Okay. Anything else?
Now, what is the movement of the spine? Clinically, you have examined. No, what is
Yes.
the movement of the spine?
Sir, lateral bending is also reduced.
Well, there seems to even facet joints also fused this X-ray. Okay.
Okay.
Shape of the ribs is altered. Shape of the ribs is like
Club shape, almost small base bat shape, club shaped ribs. So, what is it? Is there anything it is significant of?
oar-shaped.
Oar shape. Okay. It is classical of what?
Furless.
Hurlers. Oar shaped ribs. I'm not very sure. Okay. So a lot of findings in this patient. Okay.
Cervical spine X-rays, anything you have taken? Because you said short neck. Anything you have not taken. Any
Okay.
C1, C2 junctions, all those things. Is it important?
Atlantoaxial instability is common.
Okay. So with this, what do you want to do now? Because we have to go for the next.
evaluate the patient
Okay.
for the cause. Evaluate the patient for the cause of the left hip problems.
Okay. How do you evaluate?
Routine blood investigations with inflammatory markers and investigations to rule out storage disorders.
Okay. So the patient has to be evaluated. Very important, right? For the left hip, so that will leave it to the medical people, right? Then
Left hip, I would discuss with the patient and offer a surgery for a painless, stable mobile hips.
any other investigation you want to do for the left hip?
Biopsies.
Biopsy. Why?
Case of storage disorder.
So for making a diagnosis, you want to submit him for a surgery. Then any other investigation you need to do? Anybody from Stanley? Anybody here? Huh? Huh? Enapa? Okay, very good. Spinopelvic movement for doing the procedure. Before that, MRI. Why do you want to do? Very good. Most important. So whether the other hip is involved or not, you need to find out. So more important than left hip, which is already gone. There is no salvage. The right hip has to be protected. Okay. So for you need MRI for that.
Yes.
Okay. MRI is done.
MRI done.
இருக்கே ஸ்பைன் இருக்கே முன்னாடி அடுத்ததுப்போ சார் கேட்டதில்ல அவன் மேல
Cervical spine. Cervical
மேல
spine.
இல்ல அங்க வரைக்கும் கொஞ்சம் தான் இருக்கு ஓகே so what else you will see mandibular sternal angle go back so what do you see in the mandibular sternal angle so in storage disorders the Marquez disease it will be 90 degree almost mandibular sternal angle okay next there is a scoliosis which has found out bending films okay next next T2 so right hip is reported normal okay anything there are some patchy areas I know normal okay anything any further questions or anything from no he needs further evaluation just this alone is not enough
With
arthritis no,
Sir,
dysplasia no that is all right but dysplasia I will not put it so some spectrum of disorder in which the left hip is involved arthritis you have to evaluate hematological yeah anything from there
Sir, with X-rays, entire femoral head is involved with osteophyte formations. So avascular necrosis.
Yeah, that is a possibility.
Can
Strongly, that is a possibility. Avascular necrosis, collapse. So the logic, what you said, is absolutely good. If you are not able to justify that, then I may not be happy. So if you say that this is a storage disorder, spine is involved disproportionately, and all these other features, pot belly, and the loss of hair, facial hair. So I am thinking in terms of a storage disorder, and it may be a spectrum. In that, there may be a avascular necrosis. That is perfect. And the radiologically also, it can. Anything? Professor Mohan, Ram Prasad, or Prabhakar, anybody? Anything? Before we.
Yes, sir. The apt diagnosis is what you said is because of the findings in the spine as well as in the hip, which is unilateral, not a bilateral. So that rules out all dysplastic conditions. And we can, I think most of the time this fits into the more of a storage diseases. So
Yes.
the investigation should be on the line of this, and the further evaluation should be on in this line only. I
Yes.
think.
Okay. So if that is that,
Management.
Totally
Totally
parthroplasty.
clear. That's okay, okay. Mohan, with this, we'll conclude the long case. The one interesting PowerPoint presentation. Follow this. After that, Stanley.
so there is one interesting short case which the patient is right now. Our presentation part. Whatever PowerPoint. முதல்ல right அதெல்லாம் எடுத்துருங்கப்பா. So this is a video patient who is right now here 1 week old injury when he was standing in a bike with a bike road traffic accident. This is the abrasion the patient has sustained to the right upper limb. Right, can you just play the video? So he's not able to use the right upper limb. Okay. Right. If the entire video is seen, his entire face is not seen. Why? Okay. Ah. This is a video or photo. Go back. Go back. Back na front kada pova. Right. So this is a pan brachial plexus injury. So anyone, Stanley, anyone wants to comment? What is the, so brachial plexus injury, no marks for that because I have told you. So what is the level of the lesion? Can anyone say? So what's your name?
Horner syndrome is there, sir. So ptosis, meiosis, anhidrosis. Anhidrosis we can't see. Ptosis and meiosis.
How did you find out meiosis?
Ptosis we can say.
What's your name?
Aravind. Aravind.
Aravind, very good. So you have been always called, pulled up means you are the one of the best student. Okay, so that's a very good observation. So this is most important clinical sign. Since the patient is here, I thought that we should show that. So for the benefit of the postgraduates who are just logged in, yeah, you can just put in the next slide. So you can see that the right eye, which is drooped. So what can you tell us? What are the, yeah? So what are the features of Horner syndrome?
The ptosis, meiosis, anhidrosis.
Is it full ptosis, complete ptosis?
Partial ptosis, sir.
Partial ptosis, right? Because
Meo-
complete ptosis develop in a different condition. Okay, then
Anhidrosis, enophthalmos, and loss of ciliospinal reflex.
ciliospinal plexus, right? So if all these things are there, where is the level of lesion?
Root level, sir.
Root level avulsion. Okay, just go ahead. We'll see that. So this is partial ptosis is very well seen, appreciated, and you can see the pupil size. You can appreciate that. So this is pupils which are definitely small when compared to the opposite side. Next. No, that is okay. So this is the brachial plexus. And these are the levels of lesion. So this is a preganglionic. Is it preganglionic or postganglionic nerve? Preganglionic root lesion or a postganglionic?
Preganglionic, sir. Preganglionic.
Preganglionic. Okay. So that is when you will get the sympathetic outflow from where it goes to the cervical ganglion. Then it produces the disruption. Okay, next. Okay, so this is the classification where you'll get the Horner syndrome and next. I think it's enough. We'll finish complete with this. Yeah. Anything? Okay, so now we'll go to Stanley, and Stanley will start sharing their screen and about their patient presentation. Yeah, you can start presenting. We are able to see you, but you are not able to. Yeah, start.
Sir, myself, Dr. Ilayaraja from Department of Orthopedics, Stanley Medical College. And here's a case of a 44-year male patient coming from Chennai, who is iron welding by occupation and who is right-handed dominant person. With the patient presented with the complaints of numbness over left little and ring finger for past 10 months and complaints of deformity over the left hand for the past 10 months. And patient complaints of difficulty in using left hand for the past 10 months. And patient was apparently normal 10 months back. And patient had an accidental injury at his home with a wood cutting machine over his left arm and immediately admitted in Stanley Hospital underwent an operative procedure. And patient now presented with complaints of numbness over left ring and little finger for past 10 months, which is traumatic in onset and which is not progressive and associated with some shock-like sensation intermittently in the left upper limb. And patient complains of deformity over left hand for past 10 months, which is traumatic in onset. It's not progressive. And he complains of difficulty in using left hand for past 10 months, which is traumatic in onset. And patient complains of difficulty in holding the tumbler, difficulty in holding the plate during eating, and complaints of difficulty in combing hair. And his complaints of difficulty in using a mug for toileting and bathing purposes. And he complains of difficulty in using difficulty in driving two-wheeler. And if complaints of difficulty in carrying bag and also buttoning his shirt, and difficulty in using the spoon for eating during eating. And there is no history of
So,
fever.
doctor, yeah. In short case, usually in your examination, you'll not be allowed to present so in detail. So, what is your diagnosis and some relevant history? Then we'll go for the examination. Okay, can you just tell that?
diagnosis, sir?
In the examination, short case, usually you will not be allowed to present like a long case in detail. So you have to tell us what is your diagnosis, because we have reasonably come to a diagnosis. So tell us what is your diagnosis, and then you proceed. What are the reasons why you are telling that diagnosis, right? What is your diagnosis?
Diagnosis is post-traumatic eye ulnar nerve injury on the left side, which is recovering, sir.
Recovery. Okay. And what was the initial treatment which was done for the injury? Was it an open injury or a closed injury?
An open injury, sir, due to wood cutting machine in the left
Okay.
arm and above the elbow. And they done initially nerve repair and wound closure, sir. After 4 months,
So the patient himself mentions that the nerve repair was done.
no, sir. In our in plastic surgery department, they have done.
That is right. In the examination, even if you know all those details, unless the patient says,
Okay.
so it is better not to say all those things. Okay. So closure was done, and now you say that it is a recovering ulnar nerve, high ulnar nerve palsy.
Yes, sir.
Correct? Right. Why do you say as high ulnar nerve palsy?
Yes, sir.
What are the findings?
Level of the cut injury was above the elbow, sir. Scar was present on the posterior and medial aspect of the left arms.
Yeah, can you show us that scar? Okay, right. Okay, it's clear. Right. Yeah, you tell us.
Yes.
Okay, ask him to keep down.
Clear.
Tell us your finding, examination finding, to justify that it is high ulnar nerve palsy. On examination.
Examination, the clawing is present over the
Okay.
deformity present over the left ring and little finger, which is not so prominent, and there is a wasting of muscle over the hypothenar eminence, and the wasting of the interossei and the lumbrical muscles. There is a hollowing of the intermetacarpal spaces noted, and the skin over the hypothenar eminence appears to be dry and scaly, and there is a scar of size. There is a curvilinear oblique scar which is 7 centimeter in size, present over the posterior and medial aspect, which is healed with the primary intention, and so scar is healthy and there is no discharge. On a palpation, there is a.
Is there any wasting of the forearm muscle, or is it only the hypothenar and lumbrical and intraossei, intrinsic muscles?
So only wasting of hypothenar and intrinsic muscles.
Forearm, you feel that it is normal?
It's normal.
Are you sure? So how many days now?
Sir, 10 months old.
10 months old. Okay. Let us see. So which part you would like to see for wasting in forearm?
Sir,
okay, you just proceed.
over the proximal part of the volar aspect of the forearms.
Okay, proximal medial side, just below the medial epicondyle. Okay.
On palpation, the scar is mobile and it's not other to underlying structures, and it's the scar is scar tenderness present. And on palpating the ulnar nerve on the left side, there is no thickening, and there is a point tenderness noted over the ulnar nerve just above the medial epicondyle, and the pliability of nerve is normal, and
there is a pointed tenderness over the ulnar nerve just above the medial epicondyle.
Yes.
Okay. So it is the tenderness is only over there on the nerve, nowhere else.
No, scar tenderness.
Scar is also tender. Okay.
And then on movements, all the joints are supple with passive
No,
range of
when you are right. Okay. Okay.
joints. On
Because when you are examining the neurological examination, it should not be like an orthopedic examination. Inspection, palpation, then your sensory, motor, and then finally will come the suppleness of the joint and any contractures and deformities. Okay, right, you just proceed. Examination of the nerves.
Motor examination of the left ulna now, and can see the flexor carpi. On examining the flexor carpi ulnaris, the muscle seems to be contracting and function is possible. And on examining the medial half of the flexor digitorum profundus, the muscle is contracting and muscle is functioning. And on
So,
examining
no. Contracting and functioning doesn't tell us anything. So, what is the power? How did you find out? Can you just show us how you found the functioning of the flexor carpi ulnaris? And can you just show us?
இப்படி sir, on palmar flexion of the wrist with ulnar deviation, the muscle is contracting. So we can see on the flexor carpi ulnar is contracting.
Very good. So, you want to check the normal side first and then you want to go, or you want to straight away check only? How do you compare the muscle strength?
You have to check the normal side.
Right. Is it comparable? Is it same or is it reduced?
It's same, sir.
It's same. Okay. Then
On examining the flexor digitorum profundus of the little and the ring finger, it's
okay. Show. Demonstrate.
You have to hold the middle phalanx of the ring finger and
Is it the normal side?
நடக்குப்பா.
First examine the normal side, pa.
I have to ask the we have to hold the middle phalanx and ask the patient to flex the distal interphalangeal joint of examining finger. நடக்குப்பா. He's flexing the.
Yes, he is doing, but give the resistance. Is he doing against the resistance or not? Okay, do it up.
The other side, it's coming.
நடக்குங்க. மொத்தம்.
So, should you prevent the flexion of the other fingers or not necessary?
Sir, I have to prevent flexion of other fingers.
Then it will be easier for us to isolate the right. Then
examining the dorsal interossei, the patient cannot be able to actively abduct the fingers, and patient on examining the first dorsal interossei, patient cannot be able to abduct the index fingers against with and without resistance, and on examining the
palm. Can you just show the normal side? The first dorsal interossei is on the right side and then the left.
And patient, we have to ask the patient to actively abduct all the fingers. இந்த சைடு blowing. பண்ணுங்க.
Is able to do. So why don't you check each and everything? Why you want to check everything together? Is able to do? So where will you palpate the normal first dorsal interossei? Yes.
பண்ணுங்க. வெளியே தள்ளுங்க. வெளியே தள்ளுங்க. We cannot able to do the first dorsal interossei abductions.
Okay. Then
Checking the palmar intraocular, the card test is positive, sir. Patient cannot able to hold the card with his left index and ring and middle fingers.
Can you just show that?
கார்டை பிடிப்பேன் சரிங்களா பிடிச்சுக்கணும். So
So
normal
everyone
to-
should note that it is the corresponding fingers you have to use, and it should not be any finger, or you should not hold it with thumb and index. Very good. Yes.
on doing this and on the affected side, the patient cannot able to grasp the cards.
So can you do it between the index and middle? Why do you want to do it between index and middle? Second and third finger. That is easier. He is able to hold or he is not able to hold? I think your intraocular are weaker. Okay, it is improving. Okay, then this is card test. What other test you did?
So on examining the adductor pollicis of the left side, the patient cannot able to adduct his thumb, sir, while holding the book.
So what is Igawa's test for?
What is that sign? No, first look.
It's a pro-much sign for book test, sir.
Yeah, show me.
Patient
Show
cannot able-
us. அது என்ன முடியல.
asked to patient to hold the book with the thumb and the index finger, and we has to.
Okay, right. So what are you seeing? He is able to hold?
Sir, he is holding with his thumb flexed at the interphalangeal joints.
Okay, right. Then
So what are the muscles responsible for adduction of the thumb? That means what are all the muscles involved in this patient?
So adductor pollicis and first dorsal intraocular.
First,
Palmar intraocular.
palmar intraocular.
So on checking the Igawa's test is on ask the patient to hold the face the palm dorsally, and we have to check for the middle finger inside, move the middle finger sideways. Patient in this patient cannot be able to this.
normal side you do? Side you do?
இப்படி பண்ணணும். சரி இந்த சைடு பண்ணுங்க.
And the normal side.
பண்ணுங்க இப்படி பண்ணணும். சரி Fifth. அதே மாதிரி இந்த கையில்.
So what are the nerves you are checking by this Igawa? He has to dorsiflex and then he has to go take it on either side, correct?
Yes.
Right. What are the nerves which are required for doing that?
For median nerve and ulnar nerves.
So it doesn't check the radial nerve. So how is the extension of the metacarpophalangeal joint is done?
By radial nerves.
Right. So how the extension of the interphalangeal joint is done?
By action of intraocular and lumbricals.
Which muscle predominantly? Which nerve?
There are ulnar nerves.
Ulnar nerve. Middle finger extension of the proximal interphalangeal and distal interphalangeal. Done by?
Median lumbricals.
Which nerve? Which nerve?
Sir, what is the question, sir?
No. The Igawa's test, when he extends the metacarpophalangeal joint and then takes the middle finger on either side, what are the nerves which are being checked? I was asking him.
Okay, sir.
So on extending the metacarpophalangeal joint done by posterior interosseous nerve, and abduction of the middle finger is done by ulnar nerve cells. So
Okay. Right. But how the interphalangeal joints are kept extended? So when you lift up, the interphalangeal joint has to be kept extended, right?
So it's by lumbrical action, sir.
By which nerve?
For middle finger, it's median nerve.
So the Zikawa stress essentially, actually, if you do it this way, extending the metacarpopharyngeal joint and take the middle finger on either side, it checks all the three nerves. Okay. Got it? Do you be able to understand that?
Yes, sir.
Right. Okay. Next.
So on sensory examination, patient there is loss of sensation over the medial 1.5 digits over the palmar and dorsal aspect, and also the hypothyroid eminence. There is loss of sensation, and on examining the reflexes seems to be normal, and examining the other peripheral nerves like radial nerve and median nerve on the left side appears to be normal, and lymph node examination appears to be normal, and the Tinel sign, on checking the Tinel sign is progressive, 10 centimeter below the medial epicondyle.
Can you just show us how to do a Tinel sign? Demonstrate.
So now affected side. You have to gently tap the nerve from distal to proximal along the course of the nerves. So checking for ulnar nerve.
First of all, you have to explain to the patient what you're going to do and what you expect from the patient, what response is possible. That you have to explain for the sake of audience. Already I have explained him. Now for the sake of audience.
Most important.
வந்து உங்களுக்கு ஷாக் அடிக்கிற மாதிரி இருக்கும் அங்க சொல்லுங்க. சரிங்க.
எங்க ஷாக் அடிக்கணும்? தொடர இடத்துலயா? தொடர இடத்துல ஷாக் அடிக்கணுமா இல்ல அதுக்கு டிஸ்டலா ஷாக் அடிக்கணுமா? Where should be the shocking? Shocking or something tingling or okay, whatever it is, where should the patient appreciate the shocking? The point where you are seeing or distal to that?
Distal to that. You have to gently tap along the course of the nerve from distal to proximal.
You are not tapping. It is, you are just probing or palpating. Tapping is different.
Like a parrot is, yes, parrot is hacking its food, grain.
It should be with your pulp. You are using your side.
Patient himself will do the job.
So, do it again and tell us where exactly it has come. Beautifully he is demonstrating.
10 centimeter below the medial epicondylis.
No, just ask him to tell where it is exactly. Everywhere he is tapping. Ask him to show where it is exactly. Which side it is most.
கரெக்ட்டா எங்கன்னு சொல்லுங்க. இல்ல ஒரு பாயிண்ட் சொல்லுங்க.
எந்த இடத்துல ரொம்ப ஜாஸ்தி ஷாக் அடிக்கிற மாதிரி தெரியுது.
Doctor, what is tinal march? Is it audible?
See, he is showing his hand. He is just tapping and he is showing this hand. Where is the distribution of the tingling?
Correct. That is very classical.
He himself is the author of the story. As far as tingling is concerned, I mean, Tinel sign is concerned.
Okay.
There was a question from MMC. What is progressive Tinel's? Sir,
Tinal march. It's called tinal march.
Sir was asking what is Tinel's march. And did you encounter any other march in this patient?
Sir, there is motor march present in the patient, sir.
Okay.
Tinel's march.
March. The sensation will shock-like sensation will progresses from proximal to distal, sir. With each follow-up, checking for the tinal sign is a progressive tinal march.
So that point is very important. With each follow-up, you are able to observe that you are eliciting the tinal sign progressively in a distal manner. Then it means what?
Progressive tinal march.
That means what?
Nerve
What
is
is happening?
recovering. Nerve is recovering.
Nerve is
Recovering.
regenerating.
Regenerating.
Nerve is regenerating. Okay. Sir, is it okay, sir?
Yes, okay.
Yeah.
Then define the claw hand.
The claw hand is a deformity in which there is a hyperextension at the metacarpophalangeal joint and flexion at interphalangeal joints.
Can add due to what? Hyperextension due to what? Flexion due to what? You can add that. That will make it complete. Okay. What's ulnar paradox? Where will you get?
Sir,
Able
due
to hear?
paralysis of the lumbricus and intraossei, patient is unable to flex the metacarpophalangeal joint by the action of lumbricals. He is hyperextending the metacarpophalangeal joint by the overaction of the long extensions of the hand, and the flexors of the is flexing at the interphalangeal joints due to loss of action of the medial to flexor digitorum profundus action.
Yeah, that is claw hand explanation.
Yes.
Yeah. What is ulnar paradox?
Sir, higher the injury, less severe is the deformity, sir, in ulnar injury. Lower the injury, more severe the deformity, sir. Because higher the injury, there is also nerve supply loss to flexor carpi ulnaris and flexor digitorum profundus medial to ops, sir. So the flexion at the interphalangeal joints will be less prominent, sir, due to loss of flexion due to medial.
It's prominent. Okay.
Okay.
Flexion at interphalangeal joints will be less prominent, sir. So the deformity will be looking less severe in high ulnar injuries.
Right. So what do you want to do till the patient is recovering? Now they have done a nerve repair, which you have already mentioned. And as the patient is recovering, how
Yes,
do you want to, what do you want to do? What do you want to provide the patient with?
so I can give a knuckle bender splint to prevent contracture and hyperextension of the metacarpophalangeal joint, and do regular physiotherapy and electrical stimulation to the muscles to prevent atrophies.
Okay. So if the nerve is not recovering, if the nerve is not repaired,
Okay.
so what is the other option?
You can go for nerve transfer, nerve grafting, muscle transfers.
So when will you do a nerve repair, nerve transfer, or nerve grafting? How
It will
long?
take, 18 months for nerve transfer to be done, sir. For the nerve to regenerate if it's progressive.
Why not after 18 months?
Sir?
Why not after 2 years if the patient comes? Why don't you do a nerve transfer or a nerve graft? What is the limit of 18 months or 2 years? Why you should not do a nerve graft, nerve repair, or nerve transfer after 2 years? Can you do it or you cannot do it?
The degeneration will be complete, sir, after 2 years. So you work
What
for
degeneration will be complete?
If you do the nerve transfer after a certain period, it won't work because of some degeneration. Not the actual Valerian degeneration of the affected nerve.
What gets degenerated? Anybody?
axon and
Axon degeneration, Valerian degeneration. That's what we say. Anybody here?
Yeah, yeah.
So, yeah, there someone wants to say?
Clear?
Yes,
What
yes.
plate?
And plate will get degenerated, sir.
Which one?
No sensation for no stimulation for 18 months. The muscle and plate will get
Okay, very
degenerated.
good.
So there is no use doing it nerve transfer after 18
So
months.
the end organ will get degenerated. The neuromuscular junction will get degenerated, so that no point in doing it. Okay. So can you tell one transfer for this if it is not working? One transfer for the ulnar palsy.
so you can transfer either palmaris longus or extensor carpi radialis, extensor muscle transfer can be.
Which muscle? Extensor carpi radialis, is it one muscle or two muscle?
Extensor carpi radialis longus.
No, where? That you have to say specifically.
Yes.
What are the transfers? You know that?
Yes.
So all these things you have to be very, very clear. So transfers for, especially for the radial nerve and the ulnar nerve, you have to be very clear in telling all those nerve transfers. I think it is. So it is now exactly 2 o'clock, and it is a wonderful, yeah, you have presented really well. Appreciate that you have done a good job. And I thank at this moment Professor Mohan Kumar and his team. Yeah.
The PG from MMC has done a very good job, sir. In spite of being a very tough case, he has handled it with so much of elegance, and the presentation was also seamless.
Oh.
Appreciate that particular. What is his name, sir?
He is Gokul Dev. So,
I would like
yeah.
to appreciate and sir also.
He elicited detailed history. So I think he has almost got into the diagnosis by the time he elicited all the history. It's good. His presentation is very good, sir.
Yeah.
And we are very, thankful to you, sir, for being allowing us to be a part of this ROCC prestigious program, as started by you, and then we'll be looking forward to attending frequent meeting like this for students' benefit, and hope that will continue, sir. And from our side, it is a very good moment, actually. It is learning for all the people over here, and we'll be very thankful to you, sir. Thank you, sir. Thank you, sir.
Thank you, Professor Mohan. I really appreciate and thank all the professors who have come in. Professor Ram Prasad, Professor Prabhakar was there, and Professor Ashokan, Professor Hemant Kumar. Prabhakar is there now. So all those people, professors. So this makes the success of the postgraduate, because so many, if they are there, so enthusiastically participating in this teaching program, definitely the postgraduates will be there, and this has made the session of ROCC very good. And I thank profusely Professor Tolgapian for initiating and doing this in a very grand way. So I thank Professor Tolgapian.
Thank you, sir. Thank you to Professor Tolgapian, sir, for arranging all this and then coming over and inspecting and make things look easy for us also. Thank you very much, sir.
As a token of appreciation, I'm requesting the Professor Ashokan sir to honor HOD, Professor Mohan.
In order to add, we would like to say the audio visual was also above the mentioned standards, required standards. So
really, that is a very good gesture. Thank you. And in this occasion, I want to thank the Corona Remedies people, Ramesh and Vasu, who is there, and all the entire team who have been steadfast with us from the beginning of the ROCC, and they have been continuing. I hope that they'll continue their effort, and they are doing a wonderful job. Thanks, Ramesh. Thanks.
With this, Mohan, shall we conclude with this? Thank you.